Hello, everyone. I am really sorry I can't be there due to a confluence of events, the failure of three airlines and the breaking down of the airline industry, maybe. I was not able to get from Tampa to Santa Fe in time for this panel. So my appreciation for you accommodating me for a few minutes in this sort of awkward format, and I appreciate the panel for allowing me to take a few minutes as well. I wanted to lay out the concept of clinical anthropology. It is certainly a phrase or term that, if people have heard the term before, is sometimes met with some skepticism or met with some historical baggage of its own. It's a term I've embraced. It's a term I've spent a lot of time thinking about over the last 7 or 8 years or so, building out a structure in a medical school around the concept of clinical anthropology, or to use a term I like to use a lot is a critical clinically applied anthropology. So myself, I'm a physician anthropologist, so I'm an emergency medicine physician and a critical clinically applied anthropologist. I lead a large emergency medicine healthcare team, and within that team, we actually have both myself and two other PhD faculty anthropologists and one more joining us in emergency medicine. Plus, we've trained a number of graduate students and really think about using the tools of anthropology to both drive improved patient outcomes and to find equity in disparate health outcomes, and then also to position anthropology as the way to get at social medicine issues and the social medicine space, maybe with a different lens than perhaps our public health colleagues. If we think about the concept of clinical anthropology and where it came from, it's about as old as I am. So I'm 45. I was born in 1978, and in 1978 is actually when Kleiman and Good, published the paper on cultural illness and care, which in some ways is sort of the first take of clinical anthropology, a different version of it, really setting the stage to focus on the breakdowns in communication between provider explanatory models and patient explanatory models and disease and illness. I would say that frame stuck for a while. Kleiman also a physician anthropologist as well. I'd say that frame sort of stuck around for a while. And in 1979, Leslie Alexander did a review paper that led to a conference at University of Illinois in 1981, with a number of people thinking about what the clinical anthropology space was going to look like. And you had a couple of camps already developing then. You had one camp of thinking about things really with a treatment style lens, an ethnomedicine style lens. One camp thinking about things in terms of that communication between illness and disease and explanatory models. Then you had, I think, another camp that thought there might be a more pragmatic or practical applied approach to what clinical anthropology was. However, and I think what comes back to bite that camp eventually is a lot of that approach was really thinking about where did biomedicine want to go and how can we get biomedicine there. And I want to just level set now and say our approach is really not that. Our approach is really the co-creation of treatment pathways, the co-production of knowledge, the recognition of both the patient encounter space and the intersections of healthcare as spaces where we can create new meaning in ways that disrupt the healthcare delivery system. So very different than where I think essentially things kind of won out in that conference in 1980. That conference actually was essentially published in this book by Shimkin and Gold in the early 80s. And again, focused mostly on these disparate ideas around people who are thinking about clinical anthropology at the time and where they might want to go with it. Moretzky and Kriesman really took the concept of integration of biomedical models and also that individual transactional level of the patient physician encounter and molded them together, I would say, in an applied way. That led to the clinically applied anthropology book by Kriesman and Moretzky, which a lot of this book, if you look at it, is really about thinking about why patients, likely because of outdated theories of culture, are not able to sustain or adhere to some treatment model. And I would say, obviously, at this point, this is mostly a series of concepts we move far away from, really from the disruption of critical medical anthropology in the late 80s and early 90s. We actually see almost the disappearance of the clinically applied medical anthropology approach for a long time after that, I would say, shutdown of the concepts in the early 1990s. So Shepard Hughes and some other critical medical anthropologists basically make the argument that by looking for patient adherence or by building these models, really you're just participating in a larger biomedical system, a hegemonic biomedical system that is built to manipulate other people, other patients, to do things that the physician wants them to do, or the healthcare system wants them to do, or people want to do to drive profit, and to keep that system functioning. So there's really a shift going on in the early 1990s to, more concepts of political economy, power, and population models addressing social and environmental determinants of health at that point. So I think what you start to see is some disappearance of the concept of clinical anthropology for a while. Now, having said that, in the background, there's some other interesting things happening. One, of course, is Paul Farmer's work. I think what Paul Farmer was doing is really a closer version of what we would see as clinical anthropology in this format, but almost a one size fits all lone wolf treatment style, right? In other words, recognizes there's inequities in care, and I think most importantly contributes the concept of these inequities are not driven by culture as much as they're driven by structural vulnerabilities secondary to capitalism, neo-capitalistic forces, neoliberal forces. And I think that's very important because even as a physician, he was not able to really push past the traditional medical school teaching models that culture, static concept of culture, or cultural competency are what we need as physicians to somehow improve healthcare outcomes amongst patients who are unhoused, are food insecure, or are vulnerable for a number of other reasons. And if we look globally, of course, those reasons are often because of U.S. hegemony and forces of colonialism. So I don't think it broke through the medical school education model, because I think what Farmer and that group did is mostly recognize that there are biomedical interventions that can help people with inequities. So importantly, talked about those inequities for, I think, the first time it translated to physicians, but didn't break through the entire model. So the concept of structural violence, structural vulnerability is obviously very important to where we've gone with clinical anthropology now, and moves us to a different place from where it was before, which is a reliance on cultural differences at the bedside, or explanatory model or communication gaps, to instead really start to think about how we can define care together to improve patient outcomes. One thing I think that also helped is there was sort of in the early 2000s, kind of a reintroduction of a lot of biomedical concepts into anthropology through the biocultural movement. So we saw a lot of at least biomarker testing happening. We saw a lot of traditional biomedical outcomes being thought about, things like CRP, cortisol levels for stress, pretty traditional blood pressure, low birth weight, preterm infants, at least markers that we consider pretty standard in medicine, being utilized more and more by biocultural anthropologists. And so I think that starts to set the seed that maybe there is some open space for biomedicine here as well. In 2010, Hemmings wrote a really nice paper, I think, that basically put some of the blame of the lack of use of anthropology in medicine, the lack of use of, or the lack of willingness to work with medicine, traditional biomedical medicine, with anthropologists on each other, basically saying, look, anthropology, you have not been able to change the way clinical practice is happening or the providers are being trained. So you can either keep doing what you're doing or can rethink this and maybe make some impact and change. On the other side of that coin, to medicine, it was essentially, hey, you're still at this physician-patient interaction level, but you're not really getting anywhere in terms of some mortality and other health outcome measures, or we might compare ourselves across, different spaces in the world. So you might need each other to shake things up and get somewhere different. And then right around the time that paper was published, what I think really ends up being a very important door opening for a clinical anthropology concept is ACA and the triple aim concept. They get related because they get triple aim gets put into ACA, but triple aim the train was rolling on triple aim beforehand, right? Which have to have patient outcomes, quality of care, and the patient experience. So why does that open the door? Because people who have knowledge about how to do patient experience and how to do quality of care need to enter the space, and the space is being disrupted. In other words, the space is not just about me in a room with a patient and that transaction. The space really has to be more of a team sport that is open to a number of interpretations amongst team members. And it's going to take just more than a lone physician to get us to a place that's going to have acceptable outcomes for reimbursement, for continuation of care. So I think it disrupts the space and it opens people to perhaps new models that might be able to come in. And so as that space opens, I think we can start to rethink what clinical anthropology looks like. And what it might start to look like is, instead of just that patient-physician experience or that patient-physician interaction and where those gaps were, maybe we can start thinking about clinical encounters representing moments of shared sense-making and cultural creation. So when I think about clinical anthropology and the role of anthropologists, it's not just structure, right? I think culture still plays a part, but that term culture, we're now 40 years past when the concept of clinical anthropology is introduced, and the cultural concept has moved with it. The cultural concept is much more complex. So when we think about culture and that clinical encounter, perhaps the clinical encounter itself represents these moments of shared sense making or cultural creation. And we can use that term culture to understand what's creating that moment of intersection, and it gets repeated over and over and over again. And the question becomes, we want to build out structurally competent pathways that meet patient experience and quality measures, and that are sustainable and hardwireable in healthcare systems. We have to ask, what brings people to that moment, to that intersection, to that encounter? That might be, again, partially explained by culture, but I think culture now sits more in that creation space. But it really is explained by, as we know, structural differences in health equity and vulnerability, structural vulnerability. So then you might start to think about this concept of applied clinical anthropology more as a pragmatic study of process, with interventions maybe aimed at how we disrupt first, and then improve the healthcare delivery system. And again, 40 years after some of those earlier studies, now we can integrate newer theory and newer methods and newer concepts, right? We can introduce things like critical theory with syndemics, assemblage theory, entanglement theory. You're going to hear papers throughout the panel, or talks throughout the panel, or discussions throughout the panel, people's projects that really integrate all of these things, including the project I did previously for my dissertation. Um, I I don't think that applied clinical anthropology needs to be different than other applied work for other fields, for people that want to improve the human condition. This is a key concept, I think, that help us get past some of the places we might be stuck in anthropology. Yesterday, I sat with a PhD epidemiologist in the hospital, and we talked about designing a dashboard. The day before, I was sitting talking to a PhD neuropsychologist. I talked to a lot of people who consider themselves to be in that translational space. They certainly consider themselves to be people with an academic setting, to be contributing intellectually to their field, neuropsychology, epidemiology, but also to be solving human problems. And remembering that SfAA was founded on this concept of solving um, practical problems around human relations. And so I think we can get past the hangup that it really seems like only anthropology has around doing applied work in the biomedical space. We might be able to save some human lives, and you're gonna see examples here today, or you've seen examples, depending on when they're playing the video, of pathways and approaches that I think have saved human lives just as much as a physician can save a human life, or working with the physician is really what led to the saving of the human life. So if our mission is first to improve the human condition, which we could take as a question, is that our mission? But I will offer for this conversation, I'm going to just accept that's going to be our mission, is to improve the human condition. Then I think we can say there's a space for translational applied work that moves past some of these stuck up areas. These areas are stuck on past models where we couldn't contribute directly in that space. So if we think of capitalism as the driver of which diseases are seen and unseen, which pathways are structurally built out and which are not, I'm not really sure how clinically applied anthropology couldn't be other than anything other than a critically applied clinical anthropology. Because what I really see us doing, if that's the driver, if we know health inequity is created by forces of capitalism for the most part, and we're in that space, we have to co-create solutions to problems facing people who present with the healthcare system, present in the healthcare system, secondary to these structural inequities. And we have to help drive organic outcome differences. And by doing that, by those partnerships, I think we hardwire ourselves as anthropologists speaking, ourselves in that system more. So the clinical anthropology that we talk about has to move past concerns about who is beholden to whom and who recognizes or assumes what about each other, and just go to a desire to improve the human condition and interject ourselves right into that discussion as anthropologists. And you can't just dance around the periphery to make meaning. Otherwise, it's not going to be clear to physicians what that is, what's happening, and we're going to lose life. We're going to lose the ability to contribute to that somehow. Again, if capitalism is the driver, then extractive, one of the constant things you'll hear about today is really around extractive capitalism. It's around, can we pluck people or pathways out of a complex system that otherwise would not have been seen because they don't have things like ICD-10 codes or CMS compliance measures. And if you don't know what ICD-10 codes or CMS compliance measures and quality measures and things like that are, and you want to work in the healthcare space as an applied anthropologist, I think you should learn, right? I think that we have to speak a language with each other to understand where we can actually get purchase on the things we want to do to improve patient lives. So you have to actually understand the healthcare structure itself to disrupt in a positive way, to disrupt the healthcare structure. I'll wrap up here in just a second, but I want to just make it clear too that people who work translationally can still produce anthro theory. They're not just technicians. Just like I think a physician scientist is a great model. So just like a MD, PhD physician scientist who sees patients as an applied work, right? Paul Farmer in the applied setting, seeing patients. The molecular MD, PhD who has a molecular lab solving Alzheimer's disease, still sees Alzheimer's patients, right? That's the applied work. But there's a theoretical component and methodological component to the research that they're doing. Physicists, right? I mean, you think of the history of NASA and where, new physics concepts come from, right? Applied work driving theoretical, methodological advances. So I think the academic physician scientist may be a model for the clinical anthropologist. And I think the academic approach lets the anthropologist stay true to the research and education mission instead of true to a particular group, which again helps us move past that who's beholden to who. If you're not beholden to me as the physician, but instead beholden to the healthcare system improvement, to the academic concept of healthcare system improvement with the goal of improving human disease or human conditions and patient outcomes, I think this helps you gain an emic view of where your advocacy is needed and what questions really need to exist. I'll just wrap up by saying in my own work, I really try to drive this home. I really focus a lot on trying to create syndemic interventions using biomedical techniques, meaning, just like Farmer was open to the idea of treating people with pharmaceutical medications because, for example, antiretroviral therapy and HIV saves people's lives. I've been open to the same thing. But in a space specific where we might see a syndemic exist, opioid use disorder and hepatitis C and social vulnerability, how can we take all that and actually co-locate care together for those patients? How can we start to hold some social science concepts to the same rigor, but also make them just as applicable in the biomedical space? Can we take a structural vulnerability checklist, use it to risk stratify patients to improve interventions? So I will stop there. I appreciate this panel very much. I think this discussion will be very interesting for you. And please consider that there is still a space and a growing space for a critical clinically applied medical anthropology. And with that, I will stop talking and say thank you.